All right, welcome everyone. Welcome to Misdiagnosis or Malfeasance, Fact or Fiction. We got Dr. Joe Sowka here tonight from Center for Sight doing our webinar. Dr. Joe Sowka is an attending optometric physician at Center for Sight for Sarasota and Venice, Florida, which is a large medical surgical practice where he focuses on glaucoma and neuro-ophthalmic disease management. Joe is the residency education coordinator at Center for Sight. He is also the director of optometric business development for USI. He was formerly professor of optometry at Nova Southeastern University College of Optometry for 28 years, where he served numerous academic and administrative roles. Dr. Sowka is a founding member of both the Optometric Glaucoma Society and Optometric Retina Society. He is also the founder and former chair of the Neuro-Ophthalmic Disorders and Optometry Special Interest Group for the American Academy of Optometry. Dr. Sowka is a glaucoma diplomate of the American Academy of Optometry, and in 2001 and 22, he was ranked number 4 optometrist in the U.S. Newsweek magazine America Best Eye Doctor list. Joe didn't stop there, because he is now this year ranked number 1 optometrist in the U.S. Newsweek ratings. He is a partner and co-owner of Optometric Education Consultants. Joe is a great friend. Joe, the podium and virtual floor is all yours. Please welcome Joe with that virtual round of applause.
Thank you very much, Greg. And I would be remiss to not remind the audience, Greg was also in the top list. In 2023, top eye doctors in America. So congratulations to you, Greg. You're number 1, I'm number 1. It doesn't matter as long as one of us is there.
That's right. Thank you, sir.
These are my disclosures. I'm the Speakers Bureau for Bausch & Lomb. Most important, all relevant relationships have been mitigated with Greg. I own Optometric Education Consultants, and I have created the content of this lecture on my own. And a further disclosure, and you'll see what I mean in a little bit, nothing stated during this lecture should be remotely construed as being fair, and you'll understand that probably a bit later. So we're going to start off academically with some common preventable causes of catastrophic patient injury. And this is where we need to be wary. Misdiagnoses and malfeasance. Giant cell arteritis is a common one. I have embarked on my 4th medical malpractice case involving giant cell arteritis as an expert witness. It is so varied. There's plenty of blame to go around. I can miss it. Greg can miss it. We can all miss it. Posterior vitreal detachment and retinal detachment ensuing. Just because a patient develops a retinal detachment doesn't necessarily mean the optometrist should be sued, but unfortunately, in many cases, they will be. Dealing with infectious keratitis. Often there's a failure to ask, what else can it be? And we have to be able to balance the time needed for a treatment to take effect versus going too long on a misdiagnosis. Optic atrophy is a term that is used very cavalierly and shouldn't be used unless you mean it and are willing to run it down. Also, the eye not correctable to 20/20 or unexplained symptoms. Don't be afraid to run things down. I don't think I've ever seen an episode where an optometrist was criticized for doing too much. 74-year-old male patient presents with the worst headache of his life. Sees a physician assistant in the emergency room department who is supervised by an emergency department physician, saw a cardiologist, a nurse practitioner, and 3 optometrists all over a 3-week period. Now, during this 3-week period of coming back and not getting better, histories, when we accumulate them, eye ache, jaw pain, scalp pain, facial pain, somnolence to the point he falls asleep while eating his food, malaise, and jaw claudication. He was initially diagnosed by the PA as having TMJ, temporomandibular joint dysfunction, and was prescribed an NSAID. And the emergency department physician really, I don't think, was supervising very carefully and agreed with it, despite the fact the patient could open his mouth fully. Patient comes back for follow-up, not feeling much better. They find a tick. Now he is diagnosed with Lyme disease. He was in a Lyme endemic area. And looking through the records, it was actually written down vasculitis, such as temporal artery, is highly unlikely, not GC, but somebody did order a sed-rate C-reactive protein, which came back elevated, but there's no indication the results were ever reviewed. Ultimately, an optometrist made the diagnosis, but unfortunately, it was too late. The patient went bilaterally blind despite getting steroids from the optometrist. 72-year-old female presents 6-week history of scalp pain, fatigue, weight loss, transient ischemic attacks in the right eye, goes blackout for a few moments to minutes and comes back. Goes to an optometrist with sudden loss of vision right eye, findings. No light perception right eye, 20/20 left eye, diagnosed papilledema in the right eye. Plan, refer to ophthalmology the next day. Next day goes to ophthalmology, is now no light perception in either eye and has a bilateral arteritic anterior ischemic optic neuropathy. 68-year-old female, 1-month history, sore throat, cough, ear pain, unresponsive to antibiotics. Loses vision right eye, sees a neurologist who diagnoses a Horner syndrome, but doesn't explain the vision loss. Gets referred from neurology to ophthalmology, who diagnoses a central retinal artery occlusion, and that was it. There is no workup. Was told nothing can be done. This was before our knowledge that we have today about the risk of stroke with artery occlusions, but said it's happened, it's old, there's nothing we can do. A month later, patient now suddenly loses vision in the other eye. When taking a history, find out not eating for 6 weeks prior to the initial visit because of pain while chewing. Now it's no light perception left eye, arteritic anterior ischemic optic neuropathy, pupil involved third nerve palsy, hypotony, and the other eye has a Horner syndrome, the old artery occlusion. Get the serology, sed rate 114, shouldn't be over 40, and there's a positive temporal artery biopsy. Patient was immediately put on steroids, felt better almost immediately, had no visual recovery, maintained bilateral blindness. 78-year-old female, 1-week history, acceptable in jaw pain. Family practitioner prescribes an NSAID. 2 days later, the patient has 1 hour of total vision loss in both eyes, midnight in the coal mine. The right eye comes back, left eye does not recover, it stays blind. Family practitioner immediately discontinues the NSAIDs, immediately refers to ophthalmology. Over the phone, ophthalmology office said, it sounds like an NSAID reaction. Wait a week for the NSAIDs to wear off before coming in. Next day, the patient is bilaterally blind with a sed rate of 117. So in all these cases, we're dealing with arteritic anterior ischemic optic neuropathy. This is a pallid swelling of the optic nerve. There may be some flame-shaped hemorrhages about the nerve. There may be nerve fiber layered infarcts in the form of cotton wool spots, and there's usually pain of some sort. Jaw pain, head pain, occipital pain, cranial pain, temporal pain, shoulder pain, hip pain. There's some jaw pain. They're usually uncomfortable. And there is a severe optic nerve dysfunction. Usually the fundus looks much better than the vision. You may actually see a bit of a pale swollen nerve, and otherwise a decent looking fundus, and a no light perception eye. Visual field defects, if they can be measured, and sometimes we can't measure them due to the severity of the vision loss, is 6-to-1 an inferior arcuate defect, much as what we'd see in glaucoma. Now, the risk factors for arteritic ischemic neuropathy are giant cell arteritis, or a lesser form of the disease, polymyalgia rheumatica. I believe that PMR and GCA are different ends of the spectrum of the same disease process. Where we see patients who have frank giant cell arteritis, where polymyalgia rheumatica is usually in the purview of the rheumatologist. I do have a number of patients who have polymyalgia rheumatica, and I've warned them. Double vision, sudden vision loss, anything different, you need to tell me. New headache, you need to tell me. Typically in the 70s, it is not as common under the age of 60, but over the age of 50, there's a possibility. I can guarantee you right now, if you pull up any of the peer review literature in PubMed on arteritic ischemic neuropathy or giant cell temporal arteritis, the first sentence in the first paragraph will describe it as being an autoimmune disease of patients over the age of 50. So unfortunately, by definition, medical, elderly is 50 or above. So anybody who is 50 or above, this is always on the menu. High risk bilateral involvement. 65% of patients will involve the fellow eye with an artery occlusion or an ischemic neuropathy at an average of 10 days. So this is a true emergency. Catastrophic vision loss can occur. And unfortunately, too often this condition is diagnosed when the second eye goes blind, and we don't want to do that. Now, trying to make the diagnosis, we have to ask directly about the non-visual symptoms. Headache is present in over 90% of patients. Scalp tenderness, and it doesn't have to be just temporal. It can be occipital, it can be frontal, it can be cranial. Jaw claudication is pretty diagnostic. Now, don't just ask, does it hurt when you chew? Because they may have claudication and will tell you, no, it doesn't hurt, but they get tired. It's like they're chewing a tough steak or eating beef jerky, and that's why they stop eating. Ear pain, arthralgias, temporal pain, temporal tenderness, malaise, intermittent fevers. Now, of course, we're going to do our examination. We're going to be looking for optic neuropathies, artery occlusions, signs of choroidal or retinal ischemia in terms of cotton wool spots. And if we are highly suspicious or even suspicious at all, blood work is going to get done. Cedrate, C-reactive protein, and platelets are right now at least the minimum. Now, cedrate can be lowered by statins and NSAIDs, and a lot of patients are on those medicines, so you can get a false negative. C-reactive protein not affected by statins and NSAIDs, but not always immediately available, not like a cedrate. And an elevated platelet count can actually be very helpful. It's about as quick as getting the cedrate. Now, platelet count greater than 400,000, it's not diagnostic, but it's actually more helpful than an elevated cedrate for ruling in GCA. And a normal platelet count is more accurate than a normal cedrate for ruling out GCA. So we have to add this in there too, because it can be as helpful as the cedrate. Now, my experience, and I probably order testing once, probably twice a week. I probably deal with an ischemic neuropathy about once a month because I've got an elderly population. You know, where I am in Gulf Coast, Florida, Venice, and Sarasota, it's an elderly population. So I do see this. My experience is most cases aren't borderline. Either they're really, really normal or they're really, really abnormal. I think that's fortunate. But what if you get the case that is borderline? I just had a recent patient, no vision loss, but based upon headache and some other constitutional symptoms, I ran everything. Cedrate comes out 2, very normal. Platelets under 400, very normal. CRP, a little bit abnormal. Okay, what do I do? When in doubt, rule it out. They can have some negative serology. I got a temporal artery ultrasound. It was negative. I really didn't think the patient had the disease, but there wasn't much more I can do. And I think we've met our fiduciary duty in a situation like this. Now, headache and pain in GC, if you look at the vascular distribution, carotid artery, occipital artery, lingual artery, facial artery, ophthalmic artery, temporal artery. Remember, the temporal artery involvement doesn't predicate involvement in the eye. It just happens to be the most expendable and accessible vessel we have. You don't need your temporal artery. There's a lot of blood flow up there. You don't need it. You don't need either of them on either side. They're very easy to get to. Now, you can have a negative evaluation. It doesn't mean they don't have the disease. It just means that vessel is not involved, or the pathologist may not be accurate. If you really wanted to increase the diagnostic yield, the best biopsy would be the aorta, but we actually need the aorta. But if you look at all of this, you can have temporal pain, occipital pain, pain on the top of the head, neck pain, ear pain, jaw pain, scalp pain. So pain can be anywhere. Don't just, look for it right here. Anywhere up there it can happen. Initial symptoms in giant cell in the disease. And remember, giant cell arteritis is actually the most common chronic vasculitis in adults. It's a chronic disease. Patients can have exacerbations and remissions. I mean, a lot of patients will end up with an ophthalmic infarct, but patients can actually get better from this disease, and then it can get worse again. It's not like their head's going to explode immediately. But initial symptoms: headache, polymyalgia rheumatica. I have here hair, chair, stare, and fair. Hair, it hurts when they comb their hair. Chair, it's tough for them to get out of their chair. Stare, walking upstairs is difficult. And I put in fair because this was largely felt to be a Caucasian disease. Now, the reason it was thought to be a Caucasian disease, it was based upon a population study where the majority of patients in this population with giant cell arteritis were Caucasian. Important to recognize in this situation, it was done in Olmsted County, Minnesota, predominantly a Caucasian population. Same population study done in Baltimore, Maryland, about 30% of cases were patients of color. Fever of unknown origin, visual symptoms without vision loss, transient double vision, transient ischemic attacks. They lose vision for a few moments. Weakness, malaise, fatigue. What do all these things have in common? Well, they can all have a normal examination. So it's important to be looking for the symptoms in elderly people. An elderly patient starts to mention headache, I'm just going to start going down this pathway. Here's a nice example. I just saw this patient a couple of weeks ago. I almost missed the case. She's a 78-year-old female who I've seen before. She has intermittent right scalp pain. It begins in the morning, dissipates throughout the day, doesn't happen every day. Happened today, the day I saw her. It already dissipated by the time I saw her. Her exam was completely normal. The question is this something I need to worry about? Well, I didn't really think that giant cell was an issue here. In fact, I wrote headache, doubt giant cell or herpes zoster, but will order serology. And it comes back, everything's about double. SED rate was 68, CRP was 16.6, should only be 8. I don't remember the platelets are, but they were elevated. So got a little bit of a surprise, put the patient on 80 milligrams of prednisone with her PCP and referred her to a rheumatologist. We got a temporal artery ultrasound, which ultimately was negative, but clinically she has the disease. So remember, giant cell is the most common chronic adult vasculitis that's out there. It can be there for a very long time without blinding them, and then it builds up and they can have that infarct. So vision loss and ocular findings in giant cell. Anterior ischemic optic neuropathy accounts for most of the vision loss in giant cell. A small proportion of central retinal artery occlusions will be not from emboli, but from thrombosis from giant cell. The reason that it's a small percentage of only about 5% is the central retinal artery is just generally too small to be involved. There's only a small portion of the central retinal artery that actually has the vascular wall constituencies that will be affected in giant cell. Posterior ischemic optic neuropathy, where the vision is terrible. There's an afferent defect, but the fundus looks good. Transient ischemic attacks, and of course, transient double vision. I put this up here as if you want to, well, this is a nice resource slide. If you want to take a picture of it, go right ahead so you have it on your phone. Diagnosing arteritic ischemic neuropathy, we look for the prodromic symptoms. Sed rate and C-reactive protein together, very high sensitivity and specificity. And of course, an elevated platelet count is very helpful. We're going to do our ophthalmoscopic examination. Fluorescein angiography, if it can be quickly done, will show some choroidal non-filling because of involvement of the ciliary circulation. Now, temporal artery biopsy, again, not all pathologists are created equal. I've seen biopsies that were negative become positive when they're reread. You may actually get a negative biopsy, but read the report. I don't look at cell slides, but I read the report. It may say no giant cells, no active arteritis. Important to understand, only about half the cases will actually have giant cells. But if it says focal interruption of the interoelastic lamina, that's a healed arteritis and they have the disease. More and more now, if a patient is hospitalized for the evaluation, more likely than not, they'll get a biopsy, just easier. They have surgeons available. On an outpatient basis, I'm doing temporal artery ultrasounds. Temporal artery ultrasounds with a good ultrasonographer is pretty close to as accurate as temporal artery biopsy. Now, keep in mind, a negative result does not definitively rule out the disease. And you have to be comfortable with the person performing it. In Sarasota, we have a vascular surgeon who I can get it done within a day, so it works out very well. Treatment: do you need steroids? Probably IV steroids when vision loss is present. It's very effective in preventing second eye involvement, sometimes restores vision, but it's best being done through the emergency room. And here is the dosing: 250 milligrams solumedrol 4 times a day for 3 days, followed by oral steroids, 60 to 80 milligrams prednisone a day until seen by rheumatology. And the reason I put this here is whenever I send patients to the ER, I always get a call back because I give them my cell phone, and they'll ask me, what is a dosage? What is a route of administration? How long do we keep them? What do I do on discharge? And when there's vision loss, now there's a biologic agent that has been approved for giant cell called tocilizumab, Actemra. Challenge is it's expensive. It's on a very restricted formulary. Only rheumatologists are allowed to use it, and nobody really knows when to stop using it. But people now are getting put more on tocilizumab in addition to steroids when there's vision loss. And I can have that conversation with the ER physician when she or he calls me. 66-year-old female, new sudden vision loss. She's 2400, but she's been 2400 from a long-standing macular scar. So that hasn't changed. But she noticed an inferior loss of her field for about a day. And when doing a visual field, she has a new inferior arcuate defect. Looking at the patient, mild pallor, mild disc edema, no hemorrhages, no disc telangiectasia. Left eye has got a small crowded disc at risk, less than 0.2. Looks like a very classic risk for non-arteritic anterior ischemic optic neuropathy. Has mild headache relieved by an over-the-counter analgesic. has a little malaise and loss of appetite, lost 7 pounds over 4 weeks. She has no jaw claudication or temporal pain. In fact, she's not a woman in distress at all. She looks like a typical Sarasota suburbanite. She was sitting there in her tennis outfit. The question is, what do we do? Do we ascribe this to a non-arteritic anterior ischemic optic neuropathy? Well, we have to look. It's a 66-year-old person who has sudden vision loss. And this is exactly the kind of person that we're going to work up. Sent to the ER, drew the blood, said rate 96, got a call from the ER physician asking about dosing. We had a nice consult. Patient was admitted to the hospital and maintained her vision in the fellow eye. So sometimes when we're wondering what to do, we have to step back. And I'll give you this case that I easily could have missed a couple weeks ago. You know, she had intermittent right scalp pain. It dissipated. It wasn't her chief complaint. And we sometimes we just have to sit back and read the history to ourselves. Sometimes read the history out loud, and how does it sound? And as I look at it, wondering what to do, I read a history that says 78-year-old female with intermittent right scalp pain. Just saying it tells you what you need to do. So sometimes if you're wondering, think about it medical legally. If this were read to a jury, how does it sound? So any acute vision loss in the elderly is giant cell until proven otherwise. And by elderly, fortunately, it's 50 and above. Don't hate the player, hate the game. Greg, we got anything up in the chat I should be aware of?
Just a nice comment. Brandy made a comment about both cases of GCA that she had diagnosed were women in their early 50s with a cranial nerve 3 palsy as a presenting symptom, but extensive systemic symptoms upon probing, something to keep in mind when it's non-textbook. That was the comment.
Very good, Brandy. Let me tell you about it. Let me tell you, Brandy, and everybody else about a case. 80-year-old female has lost 12 pounds because she can't eat. It hurts when she chews. She had 3 days of intermittent double vision, one hour of total vision loss that's come back. It hurts when she chews. She has a constant headache and feels terrible. Pretty straightforward, right? That's not how they come in. Anybody can, my grandmother can die. She told me, that's giant cell. Come on now. They don't come in like that. Brandy is right. We have to keep ourselves open. I actually last week had a third nerve palsy where I did not find out or did not receive the GCA testing, but it does look to be ischemic. Case 30, but Brandy, you're right. Textbook cases are only found in textbooks. If they're all 80 years old with headaches, anorexia, and jaw claudication and scalp pain, we'd never miss the disease. Case, 31-year-old female, chief complaint, temporal blind spot, left eye for a year. Ocular history, amblyopia left eye with childhood patching. Medical history, no menstruation since discontinuing birth control pills. Physician said, enjoy it while it lasts. Another physician asked, do you have galactorrhea? She said, no. Reason is she didn't know what galactorrhea was. We take a look and you can see a good-looking optic nerve, well perfused in the right eye. This is, of course, a little bit magnified, small cup, but it looks like there is some degree of temporal pallor there. And when we run a visual field, we see that there is a bitemporal defect indicating a pituitary adenoma, and that's why she was having breast milk production and was not menstruating. So be very careful of this condition called optic atrophy. I guess it's a diagnosis, but it's not a complete diagnosis. Now, pallor is not a diagnosis. Pallor is a finding. Optic atrophy is a diagnosis, but you have to try to find out what the cause is. It's often a cavalierly used term. If you don't investigate it, you might as well say, I think the patient has a brain tumor, but I choose to do nothing about it. There are 6 criteria for optic atrophy. You have to have pallor, a nerve fiber layer defect, a pupil defect, a field defect, a color defect, and a vision defect. And don't assume it's all. You have to prove it. Now, you may see a patient who has disc pallor. It may be unilateral, it may be bilateral. Now, if there's no vision loss, no pupil abnormalities, no color abnormalities, no field loss, well, then you might be looking at something like a pseudophakic pseudopallor or just a naturally pale nerve. But optic atrophy has all of these criteria. Primary optic atrophy is a uniform nerve fiber degeneration resulting in glial replacement. But the optic nerve looks pretty well normal. It can be a chalky white appearance, but the margins are distinct. The retinal vessels are normal. And this is common in patients who have trauma to the nerve or compressive lesions, such as tumor or thyroid ophthalmopathy. Secondary optic atrophy comes from chronic disc edema, malignant hypertension, papilledema, infiltrative disease, leukemia, sarcoidosis. Here's a patient who was a glaucoma patient, and we can see pressure is actually in the 30s, and that can often be the red herring. Large cupping, but well perfused, and looking at right to left eye, we can see there's segmental disc pallor from 12 o'clock until 3 o'clock. And this is a patient that I'm not going to ascribe as being glaucomatous alone, is really just ocular hypertension, but we had to do a rundown with imaging on this patient. Consecutive optic atrophy from degenerative retinal conditions, retinitis pigmentosa, pathologic myopia, old artery occlusion, but don't assume that happened. You have to have a good history about it. They're pale, the nerve is pale and waxy, the margins are normal, and the vasculature, particularly the arterioles, are very attenuated. And temporal disc pallor, if it's bilateral, it can be toxic nutritional, or it can be demyelinating if it's unilateral, such as an old optic neuritis. But we can't surmise or make the findings fit our conclusions. This is what probably happened. They probably had an ischemic neuropathy. They probably had an optic neuritis. They probably had an artery occlusion. When we do the probably hads, we're going to probably make a mistake. I've seen the term occult optic neuritis, and I just don't buy it. That's usually a very painful condition. It's very hard for me to accept patients wouldn't recognize optic neuritis if they had it. Now, dealing with this, there are a lot of etiologies: infarction, infection, infiltration, inflammation, trauma, toxicity, mitochondrial disease, compression of the nerve, or chiasm. These patients are going to need MRI of the orbits and chiasm and the brain, and these are 2 different studies, with and without contrast, and fat suppression for the orbits in a high field scanning unit. In fact, I just got a call, was a Thursday, about a patient who's going in for imaging tomorrow, and they needed me to, the imaging center needed me to write on very specifically, even though it was on the note, but I had to write on very specifically to do contrast on both studies. Contrast digadolinium is going to identify malignant lesions, demyelinating plaques, which may be indicative of multiple sclerosis. But all cases of pallor optic atrophy really must be investigated or explained. You've got a large, I see a patient with a large macular scar, temporal optic atrophy. I'm good with it. All right, I'm good with it. Patient with a known artery occlusion that we know that happened in fact, I'm good with that. Patient has extensive PRP and the nerve is a little bit pale. I'm still good with all of that. but don't make the findings fit your conclusions. Keratitis and malpractice. An up-and-comer, in my experience, is alleged mismanagement of keratitis. Now, few people can argue with a good outcome, but some still will. And where can we be looking here? Well, in those that you're using steroids for, they should be followed very carefully. I'm not going to, Greg and I are not going to sit here and tell you not to use steroids. You may need to use them judiciously on the cornea. Always consider herpes as a possibility, and always consider alternate diagnosis if things are not responding. You've got to consider fungus and protozoan. Now, most people are going to treat for bacteria. Why? They are readily available. Antibiotics are readily available. Very easy to use, very effective. Most keratitises are bacterial. They're ubiquitous. And I can almost virtually guarantee if you're treating a patient with a suspected bacterial keratitis that is not responding or getting worse, and you send to a specialist, she or he almost always will start treating for bacterial keratitis. They will treat for the same thing with different medicines. We also need to temper how much time is needed for a response to therapy versus when to do something different. My experience is if there's a bad outcome, the first question is going to be asked is, where's the culture? And if there's a bad outcome, the second question is, why didn't you refer to a corneal specialist? So always keep that in mind when dealing with the tougher corneas. Now, I'm going to talk a little bit about microbiologic evaluation. We've got traditional culture. There's a study came out about a year ago looking at traditional cultures with plates, agar, scraping, platinum spatula, in vivo confocal microscopy, looking at the cornea live, but that is really university-based, and a newer technique called polymerase chain reaction. And the study looked at all three for microbial keratitis. And they found that traditional culture is best for bacteria. Confocal microscopy outperformed both PCR and cultures for fungus, and both confocal microscopy and PCR is better than traditional cultures for acanthamoeba, and recommended a multimodal approach. And I can tell you that is just not practical outside a university setting. But at least a cursory microbiologic evaluation is going to be very important. And that's why I'm going to talk a little bit about polymerase chain reaction. This is a technique allowing for a rapid and specific diagnosis of infectious disease by bacteria, viruses, protozoan, fungus, and it will identify things that just can't be cultivated or can't grow or slow growing, such as mycobacteria, anaerobic bacteria, or some viruses. Now, I use this extensively. I told Greg about it. Greg now uses it extensively. This is my microbiology lab right here. This is our kit that we use. This is a transport media. It just transports the organism. This is a run-of-the-mill label maker that we put the patient's name, phone number, date of birth. We label this for the patient. You can probably do without this, but I like having it. This is the Steriflock, which collects the organism. All gets put in this biohazard, put in a UPS, call for a pickup, and I can tell you within about 2 days, I'm going to have some information. Now, this is the new generation of quote-unquote culture rec. We are not doing cultures. We're not plating anything. We're collecting inoculum to be identified in the lab. I can tell you, when you look at this under the microscope, it's like a Brillo pad. This is not a Q-tip. This can actually denude the whole. You can remove the epithelium of the entire cornea with this thing. And this is just a printout that I get, or what is being tested for: Acanthamoeba, Aspergillus, Neisseria, E. coli, Haemophilus, Pseudomonas. Look at all the things that it will test for. Now, caveat: it's not great for fungus, but it's better than nothing. And this is a printout that we're going to get. This is a recent patient of mine. We had some staph species detected at 600,000 copies per milliliter, and that is considered moderate growth. Now, there are some normal flora that can get in there, but when we look at moderate to high growth, that really kind of tells us that's the organism that that is causative. And it will give us a summary of antibiotics of best activity, good activity, variable activity, or resistant. Caveat: it only has a few of the topicals: ciprofloxacin, this is ophthalmic, ofloxacin, levofloxacin, moxifloxacin. So it will tell you what it is most susceptible to, and sometimes you can be surprised. So we can rapidly identify infectious diseases, even those things that are slow growing. Now, having done this, I don't do this on corneal abrasions, but any sort of what I think is a potentially infectious keratitis, I'm going to do it. And here's a nice example of a small, somewhat marginal infiltrate with a fair amount of anger to the eye, mild anterior chamber reaction, staining of that infiltrate. And we've always wondered, this is one of those gray zones. Is it infectious, not infectious? I can tell you from testing all of these lesions, they're infectious. The ones that you think or you're not sure about, I can tell you pretty much they're all infectious. And often it's polymicrobial. There might be more than one organism involved. So for that, I always recommend prescribing 2 agents for maximal coverage. Don't just use one fluoroquinolone, but use something else like a tobramycin or a polytrim, something like that for additional coverage. Now, I'm not promoting anybody or anything. The company that we use is HealthTrack RX. It's healthtrackrx.com. Turnaround time is a day and a half to 2 days. They provide all the materials, no cost. They bill the patient or bill the insurance. The cost, if it were self-pay, is somewhere between $125 and $150. And there is a procedural code, 65430, scraping of the cornea for smear and or culture. It reimburses at $109 in our area. Give you a couple examples where this was very helpful. I had a patient who I did not do this on. She had what looked to be a mild infectious keratitis, was treated with a fluoroquinolone. After about 10 days, she slowly got better. 6 weeks later, she comes back and she has an infiltrate elsewhere. And I'm not talking a small little round infiltrate like this, but a fairly extensive irregular infiltrate. At this point, now I did do a PCR evaluation, and it came back that there were 3 organisms. 2 were very susceptible to moxifloxacin. 1 was not susceptible. In fact, it was resistant to most everything except oral doxycycline, which is not a medicine I would think to use. I called it in. She got rapidly better. Another example in our practice, my resident just saw a patient, patient with a history of herpes, presumptive bacterial keratitis, comes in, gets PCR'd, and turns out it is actually acanthamoeba. Grant, I know you've been doing this. Any comments you want to share or add in here?
No, I mean, you kind of hit them all. The polymicrobial is probably the one that I like to point out. You'll probably pick up some normal flora, but like Joe said, it's most of them are infectious. Even probably the sterile ones, it started off infectious. You got your immune system. Probably if you have multiple lesions, that's probably another reason to consider doing this.
In treating acanthamoeba, and hopefully nobody ever has to do this, but The medication's very, very uncommon. PHMB, which I think is an antiseptic, is made, I think, by one place, one pharmacy in the country. And the other medicine used Broline. Greg, any idea where you get Broline from?
I get it from a pool supply place because they use it in pools. I don't know. That'd be my suggestion.
Pretty close. eBay. There's actually Broline eye drops out there, and we have to identify. We have to send the patient to eBay to buy them. So, unusual, exotic lifestyles lead to exotic conjunctivitis, I guess.
There you go.
Anything going in the chat room I should be aware of, Greg?
Nope, everything's quiet.
All right. Let's talk about vitreous detachment and retinal detachment. As a patient age, the vitreous is supported by is collagen sheet supported by hyaluronic acid. As one ages, hyaluronic acid decreases. It forms pockets of liquid vitreous called lacunae, and over time, what will happen is it'll collapse in the vitreous detachment, which we all know. We all see this. One study looking at 589 symptomatic patients, floaters, those presenting with diffuse spots, about 50% had a retinal tear. Vitreal cells, 65% had a retinal tear, and vitreous blood, 91% had a retinal tear. And a lot of those diffuse spots were really from blood. Now, when I'm examining these patients, first thing I'm going to do is I'm going to be looking for the Weiss ring, and I'm looking for, is it a clear Weiss ring or is it a bloody Weiss ring? And a bloody Weiss ring makes me a little bit more concerned. Now, I will do first off biomicroscopic evaluation with a 90 diopter lens. Look left, right, up and to the right, up and left. But one of the most important places to look is in the inferior mid-periphery. Here's two patients who had hemorrhagic PVDs. We can see the linear tears, or not the linear pre-retinal hemorrhage just due to gravity. Now, here's a caveat. When I was looking at these patients upright, I could see the hemorrhage inferiorly. When I reclined them to do scleral indentation, I couldn't find the hemorrhage again. It all spread out. I would sit them back up again, and the blood would accumulate inferiorly. So when dealing with this, probably best to look at a patient upright and reclined as well.
Sounds like kind of like a human snow globe.
Yeah, it is. Now, with acute PVD, there's a 15% chance to have retinal tear. So think about that going in when the patient presents with this urgently. And of these, half will have more than one. Now, if there are no defects, repeat the examination a week to two. Most complications happen within the first 6 weeks. The risk of a late onset break is about 3 to 5%. Now, doing medical malpractice cases, most cases that I've seen usually progress on to involve a retinal detachment in the first week to two. So if you're a person who brings them back for a repeat fundus evaluation, I do recommend it. If you're a bring them back sort of person, nobody has a standard. I've asked 4 weeks, 6 weeks, 8 weeks, 1 week, 2 weeks, all right, a week to 2 weeks. That's where you're going to have most of the complications. Now, research has looked at it and found or recommended or said only those patients with increasing symptoms should be brought back for a routine follow-up. However, not everybody has adopted this policy and philosophy. I don't recommend that you do that either. If I'm defending you, I would go to this literature in a malpractice case, but I still recommend bringing them back. I can think of one case probably several months ago. Patient's symptoms actually disappeared. First thing I saw was a large retinal tear. Now, if it's complicated with vitreous or pre-retinal hemorrhage, you don't see a break, and you need to look with a 3-mirror lens, a 90 lens, scleral depression, consult the psychic, whatever you have to do. Look at them every 1 to 2 weeks for about 6 weeks. or get a second opinion, or refer to retinal. A retinal specialist probably would not criticize you for doing this. If there's no break, look at him regularly until the hemorrhage clears. You always got to worry that we tore a blood vessel and there's a retinal break out there somewhere. Now, if you never find a break, then likely it's rupture of the superficial disc capillaries caused by the PVD when it comes off, and that's fairly common. Now, a small amount of inferior hemorrhage like this, or a bloody Weiss ring just on the back face, I can live with. The larger amounts where if you can't see all the funness, that's concerning. There likely is a tear, and that should be sent to a retinal specialist if you can't see. And remarkably, I've had cases where I couldn't really examine the eye. Within a day, the retinal specialist, with photographs, it was actually, gets visibly better. Now record everything you do, what drops you've used, what lens you used, that you saw the ora serrata 360 degrees, scleral depression. If you did it, don't lie. And if you examine the upright and or supine, write it down. Here's a case of a retinal detachment. Patient complained of floaters, was examined by an optometrist who dilated, performs BIO, retina's intact, warning signs, symptoms, retinal detachment, return immediately if you have any changes. Patient has vision reduction on a Thursday, gets worse on a Friday, wants to see if it'll clear up, comes in Monday with a macular off RD. Sues the optometrist. Now, I was defending this optometrist. They had another expert witness, another optometrist who was hired by the plaintiff's attorney to opine against this optometrist. And when it was brought up in deposition to this doctor, the attorney says, but he performed BIO, he looked, he dilated. Her response was, he didn't look well enough. And I think that is incredibly irresponsible for anybody to say. We don't know what happened, and to say he didn't look well enough is, in my opinion, totally irresponsible. Here's a case snatching defeat out of the jaws of victory. In medical malpractice, there is a 2-year statute of limitation to file a case from the incident. So there's 2 years. However, once a case has been filed, it can go on as long as necessary. The longest case I can think of I was ever involved in went on for 8 years. I was expert witness. Here's a case that actually went to trial and doctor prevailed. Patient presents with reduced vision 20/50, and the doctor diagnosed central serous choroidal retinopathy based upon an OCT, but didn't dilate to confirm. Now, this case was old even by those standards. This case was about 15 years old, which is, unique in my experience. That was very long. Well, the case had gone to trial, and the optometrist prevailed, and the reason they prevailed is the plaintiff had a poor expert witness. Didn't do a very good job for the client. But the verdict got overturned on appeal based upon a technicality, and they had to retry it again. So this all began 15 years ago. And keep in mind, at that time, OCT was actually relatively new. So I was asked to opine and defend the optometrist on the second go-around. And I said, I'd be happy to try to help. Please send me the records. One of the first things that showed up on the record was this. And this is a representative image, not the exact image, but it was clearly a retinal detachment. And I asked them, how did you win the first time? And they said, well, they had a poor expert witness. Our expert witness took one cut of the OCT that looked like central serous, showed the jury a picture book of OCTs. Keep in mind, this is all very new at the time. Of central serous on an OCT, they looked alike to the jury. They found in his favor. And this is one of those situations where I declined to get involved because the evidence is right there in the record. So if you're going to use the technology, interpret the result correctly. And we always hear, is the economy stupid? Now it's the record. I was asked to opine in defense in a Department of Correction case involving retinal attachment. And I agreed to do it because they said it was for the defense. But what I didn't realize until I was involved was they wanted me to defend the Department of Corrections and opine against the doctor who was an independent contractor. And here's the chart. I've redacted a few things, but overall, there's 13 words on this chart. Greg, would you want your guilt or innocent to be determined by 13 words?
Nope, not at all. Nope, a little bit more detail needed.
Fortunately, there was enough. There wasn't just enough. If it was 12 words, it would have been bad. But there was 13 words. And the one word was this right here. And can anybody tell me what that one word is? You can put in the chat. Does anybody know what that says? Follow-up ophthalmology, evaluate OS, blah, 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 blah. Can anybody tell me what that is? Okay, so no, you can't read it either. It says macula. Now, I can tell you, having worked in a prison myself as an independent contractor earlier in my career, you don't prescribe medicine and send it to the pharmacy for them to go pick up. They're incarcerated. There is a medical director who looks over everything everybody does, verifies it, and then allows the orders to be taken off. I mean, many a time I would get called if they didn't have a medicine that I prescribed. Can you use something else? Well, we should be able to figure out that says macula. I don't think an internist who's running the prison system or the medical director should be able to recognize what that is. And in the absence of not recognizing what that is, I thought it was his obligation to pick the phone, call a doctor, and ask what is the urgency here. So with that, they decided to back down and settle the case. Here's how I like to do it. All right. This is right out of one of my records right there. I have all the medicines that we use to dilate. Lenses used 90 and 20, scleral depression 360, examined upright and reclined, cup to disc ratio, posterior vitreal attachment, no vitreous hemorrhage, no cells, and there was white without pressure, tells you I was looking. I don't see records like this. I see records like this. Records like this make it very hard to sue a person. So whatever you do, put it down. The worst thing that happens when I have to ask an attorney when we're defending an optometrist, what did they do? I can't tell what they did in the record. Did they dilate? Did they use a knife? Did they what? I don't know. So it should speak for itself. So now we're going to start freestyling here a little bit. We're going to look at optometric malpractice, fact or fiction. Malpractice is a dereliction of professional duty or failure to exercise an ordinary degree or skill or learning, such as a physician, when rendering professional services. It can be an accountant, it can also be an attorney, which results in a permanent injury, loss, or damage. Is an injurious, negligent, or improper practice. Now, I do work as an expert witness. I don't know how many cases I've done. I'm going to say probably about 100. Greg, when we were in Nashville 2 weeks ago, on that Saturday, 3 cases came into me. So I've probably done, I think, at least 100 cases. As an expert witness, I have to be able to handle an adversarial situation. When I'm deposed, I'm treated only marginally better than the doctor who's being sued because they want to discredit my opinion. It's important to be fair and objective. I want to see the right thing done, meaning that if a patient has been wronged, I think they deserve redress. But I don't want to see a doctor suffer for what it would have been the natural outcome of some sort of disease process. And it's important to be balanced because when I get deposed, I'm asked a series of questions I have to answer. You don't ask me, have you ever done this before? The answer is yes. Has your opinion been disqualified in a court of law? The answer is no. Do you charge a fee for your services? The answer is yes. Do you keep the fee that you charge? The answer is no. My wife gets it. And then they'll ask, for whom do you testify? And I said, I only testify for the defense or only for the plaintiff. I will be portrayed as being biased and unbalanced. Now, the vast majority of what I do is in defense of the optometrist. Now, I have taken plaintiff cases, and I found myself in situations where I've taken plaintiff cases. I've gone back to the attorney and said, there is no case the doctor met the standard of care, and discouraged them from moving forward. And there have been situations where I've been retained to defend an optometrist, and I look and I say I can't move on because the care was egregious. Now, common errors that can occur is trying to win the case. I'm not trying to win a case. I am involved in a case of another case right now of alleged missing a retinal detachment. And the patient was examined by an optometrist with flashes and floaters. She did dilate, did 90, did BIO, and did scleral depression, saw nothing, educated the patient. Now, the patient came in several days later. According to the optometrist, the patient came in for a chemical keratitis, got something in the eye. The patient contends he came in because his flashes and floaters got worse. Well, the patient wasn't dilated at that visit and was sometime later was diagnosed with a retinal detachment. And I've told the attorney, I said, look, if you're going to, I'm going to be asked, should a person who complains of a chemical keratitis, does that person need to be dilated? I'm going to say no. Now, on direct or redirect, I'm going to be asked the question by plaintiff's attorney. Supposing that the patient complained that they had increased flashes and floaters, should that patient have been dilated? I'm not going to equivocate. I can't say, well, maybe, kind of, it depends on every situation. I told the attorney, I'm going to say yes. Yeah, sometimes you say things that are going to not be constructive to the defense. I'm going to say yes, because any paralegal worth anything will find something that I've written that says that person should be done. In fact, they can go to our YouTube channel. They probably would hear me talking about in a lecture. I told the attorney, I will give a medical opinion. It is your job to portray your client as being more believable than the patient. And that's up to you. I am not going to try to win this case. You have to win it. I'm only going to help. And think that you must go all the way. Many a time I've been hired and summarily fired because I don't toe the company line. Yeah, some patients have been legitimately wrong. Some patients are just angry looking to blame somebody. I've seen poor economies increase the rate of malpractice claims. And patient deposition, this is all reading. Patient depositions are mind-numbingly boring, but it's the assessment factor. They want to see how the patient and how the doctor will come across in front of a jury. Common complaints that I see: vision loss, field loss, loss of ability to lead a normal life, constant dizziness from field loss, intractable headache from field loss. I always enjoy saying, I was recently contacted by an attorney, plaintiff's attorney, who wanted me to take a case and opine against an optometrist, but it was a little bit too local, and I said, I'm not going to do it. But I was talking to the attorney. He's very nice. I told the attorney, I said, if defense calls me, and they did, when defense calls me, I'll probably take the case. He said, that's all right. It's no problem. But I asked, is your client saying they have intractable headache from their field loss? She said, yes. Okay. Dizziness, can't prove it, can't disprove it. Every juror understands dizziness. Headache, can't prove it, can't disprove it. Every juror understands headache. I told the attorney, I'm gonna give you a piece of advice. Your client is lying. Anytime they have dizziness or a headache from vision loss or field loss, there is no organic cause, they are lying. Fact or fiction: if you're sued for malpractice, the plaintiff's attorney will have an expert witness, an ophthalmologist that hates optometrists. Is that a fact or fiction? Put in the chat room for me, please. I hear fact, Get a fiction. Okay. It's fiction. Ophthalmologists don't make good expert witnesses in medical malpractice cases against optometrists. They have to sign an affidavit that says they're intimately familiar with the training of optometrists, and they're intimately familiar with the standard of practice of optometry, and most of them can't do that. So now we're at polling question number 1. If an attorney thinks that there's been negligence, he or she can sue you. Is that fact or is that fiction? So an attorney thinks that there's been negligence. Can that person sue you for malpractice? With the patient, of course.
Looks like we're getting there.
All right, we slow down. Wanted to share the results. Is the majority say 2/3 say facts, the other third says fiction. Answer is fiction. They just can't sue you because they want to. They have to have a medical professional opine that there has been negligence. And I have been in that situation before. Now, in all fairness, I think that if an attorney is going to a medical professional, such as, let's say, Greg, and they ask him to review the case and tell us, do you think there's malfeasance or negligence? Greg should be able to give that opinion, but should be prohibited from being hired as the expert witness, because now there is a financial incentive for them to say yes. Unfortunately, that doesn't happen. Well, here's a case: patient being treated for glaucoma, and their patient wants to sue the optometrist, and they want to know if, in my opinion, is there a case here? Now, the patient has a history of histoplasmosis with a choroidal neovascular membrane, treated about a dozen years ago with Avastin, some moderate cupping, low 20 pressures. In my opinion, diagnosis is a little dodgy, but I wasn't there. He develops an advancing field loss and acuity loss over 6 months. Gets referred to ophthalmologist, who refers to a retinal specialist, then to a neuro-ophthalmologist. Patient has an optic nerve sheath meningioma. Patient family very angry because they missed the tumor. You think this is slam dunk malfeasance, hey, Greg? You think that glaucoma case that turns out to be a tumor you've been treating for the last 2 years, that sounds pretty bad, doesn't it?
It does.
Well, I asked. Good. So, I go back to the attorney. Do you want me to tell you what you want to hear, or do you want my opinion? And she said, no, I want to know what's really, I don't know anything about the eye. I need to know this. All right. Facts, I said, patient had multiple diagnoses: glaucoma, probably, maybe. Histoplasmosis, there's some retinal vision loss. All right. Optic nerve sheath meningioma is less than 2% of all orbital tumors. And we know orbital tumors are not that common. So this is a small number of a small number. You're asking a jury to believe this reasonably prudent optometrist should have seen this. There's some delay in diagnosis, about 6 months, but would it make a difference? When the optic nerve is involved. So I explained it all, and she said, all right, thank you very much. We're not going to pursue the case. Another case, flashers and floaters. I'm asked to opine to see if they can, if there's a lawsuit that they can sue for. Patient has symptoms on a Monday, examined PVD, educated. More symptoms on a Saturday, sees the optometrist on a Sunday, who finds a retinal attachment. The patient said, the doctor said, oh crap, you have retinal attachment. He probably said, but there's no encounter. There's no encounter. He went in on a Sunday, dilated the patient, and you got a retinal attachment. So patient seen Monday by the retinal specialist. Patient is not eating since midnight, does get a surgical repair. Patient seeks an attorney, wants to sue. I'm asked to opine against the optometrist. Now, here's the record. It isn't extensive. I'm going to magnify it. History is really very good there. Acuities were on a different page. Checks off everything that was normal. One thing that was abnormal, incomplete PVD attached to periphery 360. Dilation, wick drops were used, medrosol neosynephrine, OU, dilated BIL 2090 and photos. Vitreous detachment, right eye incomplete and symptomatic. Signs, symptoms, retinal detachment turn 3 weeks sooner. This is good. It means that everything is there. This is great. Dilation was done, meds reused, lenses reused, good description of the condition. Now, he didn't put anything in for the Sunday visit, but the patient shows up NPO. All right, he had to learn that somewhere. So ergo, the exam did happen. And there was a change in symptoms consistent with the literature. And I asked the attorney, do you want my opinion? Let me tell you what you want to hear. He goes, no, I want your honest opinion. So in all medical probability, there's not a tear at the time of the examination. I don't recommend you move forward. And he said, thank you very much. I'm going to discourage the patient from moving ahead. Now, bad outcome versus malpractice. Optometrist sees a 60-year-old female for a routine examination, pressures in the upper 40s. Diagnose her as a glaucoma suspect, begins topical treatment, manages for 2 years, gets the pressure to the low to mid 20s. All right, pretty straightforward so far. 2 years later, insurance dictates she go elsewhere. Now she sees an ophthalmologist on multiple medicines. The pressure is in the mid 20s. He doesn't like it. He changed the medicine. Pressure in the low 20s. Undergoes trabeculoplasty, then trabeculectomy. Sues the optometrist, and I was actually retained by the patient's attorney to opine against the optometrist. Now, here are the allegations. Detected elevated pressure and only used topical medicines. Well, that's how glaucoma is treated, certainly by optometrists. Diagnosed glaucoma, failed to warn serious nature, he said, she said. Can work with that. Failed to diagnose and treat optic nerve injury. The attorney thought optic nerve injury and glaucoma were 2 separate things. The patient had 2 separate diseases. I had to educate him about that. And failed to refer to ophthalmologists and said he's not obligated to refer to an ophthalmologist. And that was really shocking to the attorney because when I looked at the record, it actually said in the very first visit with the ophthalmologist, saw optometrists who did not even recommend referral. So that was the case of the if onlys. If only you had been referred, I could have said, if only they did, I could have saved you. Never use the if only. You don't know what happened in somebody else's office. So, is this malpractice? Yes, very weak. The allegations are very weak. Now, let's look at the chart. Medications are obviously added, but there are no notations. No CD ratio was recorded for the first 1.5 years, and when it was wrong. One time a dilated exam was performed, nothing was recorded. No gonio was done, no fields were done, but frame style, bifocal style, seg height, PD, temple length, all charges very clear. If there's more about the materials than about the patient in the record, you're doing something wrong. So is this malpractice? Are the allegations accurate? Guys, put it in the chat room. Let me know what you think. Is this malpractice?
Joe, there was a question that came in while they're having that roll in. It says, have you ever been subpoenaed to testify after refusing to take a case as an expert witness?
Nope. No, I'm not involved in it. They can't do anything. It's up to me if I take a case or not. So everybody is saying, yes, this is malpractice. All right. So when I saw this, and it's not good. I mean, it's ugly. But 2 questions we have to ask. If he did nothing on the first visit, what would have happened? The patient got infinitely worse. And what happens to a 60-year-old woman with a pressure nearly 50 with advanced glaucoma? She's going to use all the medicines, laser, and surgery. It followed the natural history of the disease. Now, did she get worse? I don't know. There's nothing to tell me if she did or not. But this is a person who first gumped his way through it. But I went back and said, I don't believe that malpractice, the actions or alleged inactions of the optometrist contributed to the outcome. They said, thank you very much. Barring a positive opinion from you, we're going to drop the case. And they did. Cases of optometric malpractice involve obvious negligence or clearly straightforward. Is that fact or fiction? I'll tell you right now, it's fiction. They're not really black and white, but they're usually shades of gray. I was retained as a defense expert on a case of pigmentary glaucoma. Patient was non-compliant with medicine. Pressure was 32 and didn't like his medicines. So the doctor completely changed the regimen, but scheduled the patient for 6 months. Patient undergoes multiple surgeries, ends up with light perception vision, mostly from his non-adherence, but did sue 2 doctors for $2 million each. And 6 months, is that really negligent? Should have been a little bit sooner. Well, I could argue it should maybe have been a little bit sooner if he made a major change in their therapy. But again, not black and white, shades of gray. Sometimes it is black and white. I was retained as a defense expert for the optometrist. Had been seen by an optometrist for 15 years. Lost field and fixation from pigmentary glaucoma. Now, looking at the worst records I have ever seen. I mean, the CDC seemed to be like symbols. I couldn't. It was totally illegible. I mean, it was painful to get it translated to quote unquote English. But what we can see is over 15 years, pressure started at 12, ended at 29, and no evaluation is ever done. Once in a while, you bring it back, check the pressure a little bit lower, no problem. Patient lost vision under 15 years of care from a chronic disease. Recommendation settled. Now, there's no such thing as practicing defensive medicine, fact or fiction, guys. What do you think? Put that in. You can put that in the chart. And Thomas, I like your comment. Didn't record, didn't happen. I like that. All right, people are saying fiction. Reality is there's no such thing as defensive medicine. It's standard of care. Do what is right and record it. Give you a case of pigmentary glaucoma. Going patient being managed in the VA system goes to a private optometrist. Pressure is 47 because he's not using his meds. Referred emergently to another center. Seen 3 days later. Pressure is 21. Why? Because he's using his meds. Goes back 2 months later. Pressure is now 53 to the original optometrist. Referred emergently. Seen the next day. Sued the optometrist for $2 million for not referring fast enough. He referred, but when he got the intent to litigate letter, he panicked and answered himself. Said this was emergency. He kept saying emergency. He actually he did himself a disservice. I'm going to jump ahead. Majority of optometric malpractice involves inappropriate use of therapeutics. Is that fact or fiction? I'll just let you in. It's fiction. The 3 main offenders are failure to detect retinal detachment, failure to detect glaucoma, failure to detect tumor. These are acts of omission, not commission. It's failure to listen to the patient, failure to observe the signs, failure to make the diagnosis fit the findings instead of the other way around, failure to do the appropriate tests and follow-up, and failure to make the appropriate referral. 47-year-old male complains of hazy vision in his left eye, diagnosed with a microesotropia of 20/25 vision. Seen by another doctor 6 months later, diagnosed with dry eye, same visual acuity, but he keeps complaining his vision is hazy. And I think we all know amblyopes don't complain of hazy vision. Now he's got 20/70 vision and afferent defect, dyschromatopsia, looks like that. Failure to listen to the patient, said it wasn't clear. Failure to do the appropriate tests and follow-up, what should have been done? Visual field. Don't be afraid to do OCT, visual field, SID rate, C-reactive protein, or even an MRI. Failure to make the proper referral. Who's the best referral? Anybody else. So the patient's not happy, get a second opinion from any colleague that you want. Failure to observe the signs. 16-year-old male presents for contact lens fitting. Refraction +1, -1, 20/40, 20/20 the other eye. Fundus within normal limits. That's all that was written. No CD ratio. Diagnose refractive amblyopia. Fit with contact lenses. At 2 weeks follow-up, his vision is 2100 and it's a good fit. And this is the entirety of the record for that day. 1 month later, vision's 2200, but still a good fit. And that's the entirety of the record. Patient's discharged. Comes back for an annual exam. Refractive unchanged, 2400. Fundus still within normal limits. New lenses were ordered. Contact lens was dispensed. Said right lens is not clear. Another doctor in the practice picks up the ophthalmoscope, sees a retinal attachment. My recommendation, try to settle. I mean, the ship was sinking and we're just watching it.
Hey, Joe.
Yeah.
Someone asked, can we be sued if a specialist isn't able to get to see them as soon as we recommend?
The answer is anybody can sue you for anything at any time, unfortunately. We can only do our best, and unfortunately, patients can't be held responsible for their own negligence. Nothing I said, I tell you, nothing to say is going to seem fair. Failure to order proper test of referral. 58-year-old male has vision loss for right eye, diagnosed with ischemic neuropathy, both eyes, right eye worse than left, mild headache and pharyngitis. Recommended was an OCT that was ordered for the next day. Cedrate, C-reactive protein, and platelets were recommended but were not ordered. Friday OCT is performed, Saturday is interpreted. Disc swelling, more right eye than left eye. I think the doctor had a come to the Lord moment. Faxed the recommendation for the serology to a PCP ASAP, but it's on a Saturday. It sits there through Sunday, nothing happens. Monday, the internist reads the message, orders serology and carotid testing for the following Wednesday evening. Tuesday, patient wakes up, profound vision loss in the left eye now, walks into the ER, gets all the tests done, everything elevated, temporal arterized, bilaterally legally blind. Sometimes you just shake your head. I was retained for the defense. Diabetic patient sees an optometrist, diagnoses proliferative diabetic retinopathy. Educates, warns, risk permanent blindness, must see retinal specialist within 7 days. Well, unfortunately, because of insurance, this doctor was not in the patient's network, so a referral could not be done. Had to go to have another eye exam with another optometrist in the network before a referral can be done. So sees another optometrist 6 weeks later, who details a completely normal examination. 3 months later, patient is now completely visually impaired from proliferative diabetic retinopathy. And I look at this and I say, well, look, that totally turned. This is great. I mean, he saw diabetic retinopathy, warned risk permanent blindness, must see retinal specialist. This is great. Attorney goes, no, it's the other guy ready funding. Thank you very much. I'm out.
Joe, let me make a comment on this this question about can we be sued if a specialist, and Joe mentioned you could be sued at any time, but a lot of times I'm making referrals out and all the specialists are busy. So, whenever I make the request and I take it to my staff that makes the phone call, I always put a timeline in there. Like, I want this seen within 2 weeks, or I want this seen, tomorrow. The good news is I have a lot of relationships with these, and they'll take them because, it's Greg calling. But sometimes they don't know who Greg is. It's a new front staff person, and they're going, sorry, we can't get them. And that's whenever you have to say, okay, to our office, I want to make sure this patient isn't seen. And if not, let me know, and please give me the phone number, because now I have to reach out to the doc and, explain the case to them and say, look, this is why I want you to see this tomorrow. 10 times out of 10 or 9 times or 9.5 out of 10, the doc's going to say, okay, I'll see them. Thanks for the call. So don't let front desk kind of dictate it. You're the captain of the ship there. You can document that all in the chart. Even if you spoke to the specialist, then you can document that too. So just kind of follow up.
Craig is completely right about that. Sometimes you just shake your head. Part two. I was asked to defend an optometrist allegedly who have misdiagnosed pseudoexfoliative glaucoma. I agreed to get involved and try to defend. And first thing they sent me was an affidavit for me to sign, that there's no evidence of glaucoma at this time. And I said, well, I'm happy to sign it if it's true. So please send me the chart so I can look and see if it's actually true. And these photos were in the chart, and we're looking at about a 0.9 to 0.95 cup to disc ratio. And I said, I'm sorry, but there is clear evidence that glaucoma was present at this time. In fact, there's more evidence here than was in the OJ trial. Let's see, where are we here? All right. Failure to diagnose retinal detachment. 50-year-old male sees flashes and floaters, goes to his optometrist, does dilation, BIL. No breaks, no detachments recorded. Warning signs, symptoms, retinal detachment, and reappoints him for follow-up and dismisses the patient. Pretty straightforward. We see this all the time. Now, a patient has worsening of symptoms and vision loss a week later, calls the optometrist after hours, out to dinner with his wife, gets through to the answering service on the cell phone. He hears this, and he directs him to a friendly retinal specialist, goes back to dinner, forgets all about it by the next day, doesn't record this conversation in the chart. Greg, that's time for a polling question. If you pull that up. Anything not recorded in the patient's chart is considered not performed. Is that fact or is that fiction?
Okay. Looks like they're rolling in nicely.
Mm-hmm.
I'm going to end it right now. Oh, maybe one or two more. And I think that's it.
So the vast majority have said that that is a fact. Anything not in the chart was never performed. So I'm just gonna give you my opinion. That's fiction. Not written, not done is not true. I'm not going to tell you not to write things down. You really need to detail everything you've done for a patient. But if it's not in the chart, it doesn't mean it didn't happen, because information can come out other places. And the other places it can come out is at trial or in deposition. Now, I will tell you that the patient, this was a lawsuit, and the treating retinal specialist said, yeah, he called the doctor who said, come to my office. It's in the record. What I don't want you to do is try to amend anything after the fact. You can do an amendment, you can change something if it is legitimate, but you need to be very, very transparent as to when and why you are doing this. Because if you're trying to make something better than it seems or improve something, you will always be caught. By the time that you are subpoenaed for your records, the attorney already has your record. The patient came in, asked for a copy of the record, said they're moving out of the area, yada, yada, yada. And they give it to the attorney because they knew they're going to sue the optometrist. You don't want to make things or try to change it. Information can come out other places, and it comes out in deposition. So, patient had a retinal detachment, had a poor surgical outcome, and sues the optometrist for malpractice. Question is this malpractice? Was the standard of care breached? Well, could he have missed the break? The answer is yes, he could have. Could there have been a break undetectable to the best of retinal specialists? Certain. Could have been no break initially and one formed after the exam? Yes. So it's a bad outcome, but in my opinion, not malpractice. Now, I was retained by the plaintiff's attorney to opine against the optometrist. And I went back and said, well, he dilated, he did everything that he should have done. He did not breach standard of care. Well, the attorney said, I've got another optometrist that will swear on the stack of Bibles this is malpractice. My response, give him a call because I'm not going to do it. Even for, and he detailed, not a bribe, but how much money I'm going to bill him services if this goes to trial. My response is no, thank you. I was summarily fired from the case and I was very happy about that. Now, interesting, the friendly retinal specialist was deposed. They asked, could this doctor have missed the retinal break? And the retinal specialist, well, yes, it's likely he did. He's not a physician, you know. Does this bother anybody out there? Is this bothersome? Well, I don't want you to get your necks up over this. I don't think this retinal specialist meant ill. In fact, my belief is he's probably a decent person, and the optometrist, and he and the optometrist are probably still friends. But what they are looking for is the legal pot of gold. The legal pot of gold. Now, as an expert, well, I'm being paid for my opinion. You got to take that into account. What they need is to have somebody involved in the care who is not being paid say something untoward against you. And they're very good at getting this out. The attorneys know, just like we do refractions, that's what they do. They're very good. And if they can get somebody else involved in the case who's not being paid and not being sued to say something negative against you, that's their pot of gold. They've struck gold. I'm going to share with you verbatim from another deposition in another retinal detachment case from another retinal specialist. Entirely different. Okay, different. Same type of case, but different. The attorney asked, do you think that you as a medical doctor, as an ophthalmologist, are better trained and equipped to rule out or rule in a retinal attachment than an optometrist? Response from the retinal specialist, I think optometrists are trained or supposedly trained in their field to be able to do a dilated fundus exam to diagnose retinal tears or detachment as well as any other eye care professional. Attorney, you believe an optometrist has the same expertise and ability to diagnose a retinal attachment or retinal tear as you do? See, they're going for the ego. Response, setting my ego aside, I would say optometrists are trained to evaluate the peripheral retina as well as an ophthalmologist, and that's my answer. You know, depositions are uncomfortable. It's an interrogation. The attorneys are very good at drawing out the information they want to use. Here, they're going for the person's ego. He didn't bite. I was defending optometrists who allegedly missed angle closure. They had a treating ophthalmologist who opined against the optometrist and said, yeah, he probably didn't do that good a history. He probably should have done this. But, you know, then again, I might have done the same thing. And I can kind of see how I might make the same mistake. Boom. He just wrecked the case. He saved the optometrist inadvertently. Another case, optometrist was sued for infectious keratitis. I was defending her. The attorney wanted a corneal specialist involved in the case as an expert witness as well. She was very friendly with the corneal specialist, hired him. He had never done it before, out of his mind with anxiety, said a few things that kind of hurt the case. Sometimes it's black and white or worse. 55-year-old male has a weed whacker abrasion. He's working on his weed whacker. He starts it up. It hits something out in his garage floor. It ricochets off the wall and hits him in the eye. He goes to an optometrist who diagnoses a corneal abrasion, treats him for a corneal abrasion. 2 days later, sees another optometrist in the practice. She notes a shallow anterior chamber, pressure less than 5, hypopyon. Obviously, this was a penetrating injury, and he developed an endophthalmitis, had 5 retinal surgeries, and lost all of his vision in that eye. And I was asked to opine in this case, and I politely declined. And the attorney said, we at least look at the records. I said, I'll look at the records for you. And I look at the records, and it was worse than the story they told me. I mean, over the phone. It was terrible. And I went back and said, you know, I'm not interested in getting involved. And the attorney tells me, well, yours is the kindest opinion we've gotten so far. And I've got it on good authority. You have publicly stated doctors are allowed to make mistakes. So, yeah, you're right. I have said that before. Okay. So They talked me into it. And our defense was they made a mistake. The diagnosis was wrong. They didn't treat him with disrespect. They had diagnoses. They followed their diagnoses to their logical conclusion. They were just the wrong diagnoses. But they didn't treat the man with disrespect. And I was, as I expected, in deposition, the attorney hammered on me about whether or not it was standard of care to not consider endophthalmitis. And it was it's like a rope a dope. I just let him beat on me and beat on me and beat on me. After 20 minutes, he came to the conclusion I was not going to use the phrase negligent or standard of care, and he moved on. I don't know how it ended. It did settle. I was only told everybody was very happy. But that's the words I'm looking for, negligent or below standard of care. In all medical, and in this case, no less than 7 people, expert witnesses and treating physicians, all said they fell below the standard of care because they didn't see that there was a self-sealing corneal perforation. In all medical probability, the retinal braid corneal perforation, whatever it may be, was present at the time of your examination. And because you failed to see and diagnose it, you fell below the standard of care, because the standard of care dictates you were seen and diagnosed, and because you didn't, you were negligent. I've heard that in so many cases from so many expert witnesses. And this is what I think of that. Okay? I don't think very highly of this whole idea. I will tell you, here is legal standard of care. This is what would be read to a jury prior to deliberation in a medical malpractice case. Negligence is a person's failure to follow a duty of conduct imposed by law. Every provider is under a duty to use his or her best judgment in the treatment of his and care of his or her patient, to use reasonable care and diligence in the application of his or her knowledge and skill to patient care, and to provide health care in accordance with the standards of practice among members of the same healthcare profession with similar training and experience situated in the same or similar communities at the time the health care is rendered. The law does not require a provider absolute accuracy in their practice or judgment, or hold them to a standard of infallibility, nor require the utmost degree of skill and learning known only to a few in the profession. Only requires healthcare providers to have used the standards of practice exercised by members of the same healthcare profession with similar training and experience situated in the same or similar communities at the same time the healthcare is rendered. A healthcare provider does not ordinarily guarantee the correctness of the diagnosis, analysis, treatment, or judgment, and absent such a guarantee, which we will never give, a healthcare provider is not responsible for a mistake in their diagnosis, analysis, judgment, unless they violate the duties that we discussed earlier. And that is the law, my friends. I'm going to skip over this. I'm going to wrap up with this one. Greg, we're going to have to come back and reconfigure this lecture for another one just on malpractice. I never get as far as I want to get on it. My final polling question: the diagnosis is never correct. The patient can't sue for malpractice. Is that a fact or is that fiction? If it's not correct, and the patient can't sue for malpractice. Is that fact or fiction? I think it's going to be kind of an interesting turnout. So if it's never correct, the patient can't sue for malpractice. Fiction, interesting. I thought more people would bite under fact, but that's fiction. I'm going to wrap up right now with what I affectionately refer to as a festival of ignorance. Some of these cases can actually be emotionally or academically painful, not emotional, but academically painful for me. This is one such a case. 37-year-old female comes from an optometry practice referred to an ODMD Center for Pterygium Surgery. Pterygium surgery is done successfully. Patients put on Pred Forte post-op. 1 day post-op, everything's good. 1 week post-op, everything is good. Patients return to the referring practice. Comes in to see an optometrist in the practice, complains some post-operative complaints of blur, but it's very unclear. And I don't think they really had a very good assessment or good explanation, I should say. But importantly, the optometrist did not check pressure. Now, next day, patient calls back, still has some blur, wants to come back and be seen again, is now going to be seen by another optometrist, and she is in there, and she said, all right, get the patient in, it's an emergency, just get him dilated right away. Was just seen yesterday, get him back in, just get him, when they get in, just get him dilated. Okay. So dilates, and she sees a swollen optic nerve. Wants to refer to a neurologist or neuro-ophthalmologist, but that's not going to happen. He's very uncomfortable, but she does find a retinal specialist who agrees to see the patient for her. Now, she doesn't check the pressure either. The retinal specialist, friendly person, say, I'll see the patient for you, come right out. So we'd love to meet this guy. I think he was probably a wild man. So he looks at his patient's dilated. He checks the pressure. It's 49.5. It's not 50. It's not 49. It's 49.5. He thinks that she has optic neuritis because he sees a swollen nerve and she's a younger female and she has eye pain. Well, the reason she has eye pain is her pressure is 49.5, not 49, not 50, 49.5. So he gets an emergency MRI, which comes back, and it's clean because it is not optic neuritis. Oh, by the way, he also correctly identifies steroid-induced pressure rise. Now, he still believes this is optic neuritis and is having a steroid-induced pressure rise. So he logically injects a steroid into the eye to treat the optic neuritis. Greg, I don't know if you remember the results of the optic neuritis treatment trial, but intravitreal steroids is not a treatment for optic neuritis. If you're going to make a mistake, treat your mistake correctly. Very rarely do two wrongs make a right. So, all three were sued for missing a steroid-induced glaucoma. Interesting, one of the optometrists, she was a former student of mine, she called to tell me about this case and asked my opinion. She said the retinal specialist was in the process of writing a letter to the attorney to explain why they shouldn't be sued. And I said, there is no good that can come from this. What he says can and will be used against you in a court of law. Make sure, I don't care if you shoot him, stop him from writing that letter. So all three were sued for missing steroid-induced glaucoma. Greg, does any glaucoma cause a swollen optic nerve?
Not that I'm aware of.
No. The patient had a non-arteritic anterior ischemic optic neuropathy. Now, could it have been due to the pressure? Yeah, possibly. Is there any literature support to it? Absolutely not. And nobody considered this until I wrote a 5-page dissertation looking at the fields, looking at the photos, telling them exactly what the diagnosis was. Well, they're all sued, and this was the plaintiff expert witness who was an ophthalmologist because an ophthalmologist was involved. He actually said any delay in treatment was significant because the glaucoma progressed at an unusually rapid rate, and a delay even by an hour was it contributed to the poor outcome. Greg, does any glaucoma move by the hour?
Not that I'm aware of. Nope.
Nope. Disc pallor is common in glaucoma. Glaucoma happens commonly with small cups. Glaucoma is disease of cupping, but the disease of non-cupping is non-arteritic ischemic neuropathy. When the IOP is very elevated, it often causes a swollen optic nerve. I've never heard of that before. Have you, Greg?
Have not heard that one.
And you never consider ischemic neuropathy in a patient under the age of 70. I actually asked the attorney to get me a copy of his CV because I want to make sure he actually went to medical school because I got my doubts. Greg, I think we're out of time. I'm not going to be an academic terminator. I never finish off talk. I have a bunch of new other cases in here. Maybe we'll come back and just do a malpractice lecture in the new year. So with that, I am going to stop sharing my screen and turn it back, and let's bring this on home.
Perfect. And with that said, Joe, I don't see anything popping up into the chat box. Look, we were all caught up. I just lost my chat box, so please police it for any other questions. And I'll say thank you. And Joe, obviously, you know, you're one of the few in the profession that have this expertise. It's always great to hear this and hear you talk. This was Misdiagnosis or Malfeasance, Fact or Fiction. What a great job you did tonight, Joe.
Thanks, Greg. Like I said, I think we'll just reconfigure and come back next year and do an entire malpractice, because I really only scratched the surface of these cases.
Great.